All right, good afternoon, everyone. Thank you for joining us for the second of today's webinars. This one is focusing on the hemorrhage initiative. So thank you all for joining. This is Lauren Nunley. As you can see on the screen, I'm going to ask you if you would please put your phones on mute, just so that we don't have any interruptions during the session. The chat box is available. It's probably at the bottom of your screen, I think, for most people. If you haven't already done so, if you could put your name and your facility. If there are more than one of you listening in, you could add their names as well. This is just so we get an idea of who is on the call. Thank you. And also the chat box is there if you want to ask any questions, if there's anything you want to share, any links, any resources, any information, please feel free to do that. And we'll just go ahead and get started. Next slide, please, Katie. So again, every month we are revisiting our aims of these bundles and remembering that the 4 elements of the bundles are readiness, recognition and prevention, response, and reporting and systems learning. We aim for these webinars to have content that speak to these elements and hopefully to help you all in the implementation of the quality improvement initiatives in your facilities. Next slide, please. And so again, every month, for those of you that have been on these calls regularly, we are looking at quality improvement initiatives. And of course, for this hemorrhage initiative, we have an aim as a collaborative. And our aim is to reduce severe maternal morbidity in women who have had a hemorrhage by 20%. And we want to meet that goal by the end of December 2020, so in the next year. I'm not sure where we stand at that right now, but that is something that we are working on. And again, using the driver diagram, the 4 elements of the bundle: readiness, recognition, response, reporting, and systems learning, and the associated process and structure measures that go along with that to help to meet that overall goal that we've set as a collaborative. Next slide, please. So just to break that down, looking at the goals that we have to reduce SMM by December 2020, a 20% overall reduction. We also have some additional goals pertaining to this bundle. Risk assessment, that 100% of women have a risk assessment done at least once between admission and birth and shared among the team, that there's debriefing done on all cases requiring 4 or more packed red blood cells or admission to the ICU. Again, 100% debriefing on all of those cases, and 100% of QBL on women who've had measurement of blood loss. Our goal is for 100%. Next slide. So this slide does have the structure measures on there, and I wanted to relate that to the what we've talked about in the last couple of webinars and the new Joint Commission requirements. I know that there are many of the facilities that are participating in GaPQC that are accredited by the Joint Commission, and I know some of you are not. Some of you have DNV accreditation, but what we as a collaborative would like to do is to align the goals from the AIM bundle with some of the requirements from the Joint Commission, just so that we're making sure that we meet those guidelines and recommended best practice. Now, the Joint Commission, the 13 elements of performance that the Joint Commission recommend for the hemorrhage initiative, or pertaining to management of severe hemorrhage, does have some requirements for documentation. So that means that all of the facilities that are accredited by the Joint Commission will be expected to not only ensure that these structure measures are in place, but also that you've got documented evidence of that. And that's highlighted in the bold that you can see on the screen there. For the 6 process measures, there are 3 of them that will require documentation in your facilities. So you will need to, if the members of your facility that focus on ensuring that Joint Commission readiness is adhered to, if they don't already know this, it's important that you share this with them. So for structure measure 1, patient and family support, there needs to be documentation of that in the protocols, or that staff can speak to where that is documented. The same goes for debriefing as well. And for an OB hemorrhage policy and procedure that has been reviewed and updated in the last 2 to 3 years. We will continue to discuss this as an element of these elements of performance as a matter of importance in all of our webinars, and we'll continue to have open dialogue about it because we know that it is really important, and a lot of the facilities have already started to work on this. So we want to hear from you if you've done any gap analysis in your facilities, or if you have any information that you can share that you think will be beneficial to other facilities on what you are doing in your facility to get ready for this implementation beginning July of 2020. Next slide, please. And again, for the process measures pertaining to the AIM hemorrhage bundles, the documentation that will be required by the Joint Commission is that there is documentation, or that staff can speak to where there's documentation pertaining to risk assessment for all patients that have been admitted at least once from admission and until delivery. And in actual fact, with this element of performance, the Joint Commission, for those hospitals that are accredited by Joint Commission, they have another element that they've added, and we will be sending out this information with a follow-up email after this webinar. So what the Joint Commission have required is that an additional measure above and beyond what we already require for AIM, for this AIM bundle. So it's not just on a risk assessment on admission to labor and delivery, but they also require admission, another risk assessment to be done on admission to postpartum. If any of your facilities are already doing this, we would love to hear from you about how you're managing to accomplish that, and so that we can share that information. But also simultaneously, we will be looking at ways that we can provide information and resources for you if you're struggling to meet that, or if you need any ideas. And then for P5, documented evidence of QBL. So this is, even if this is already in your protocols, that's great. And if it's not, it does need to be in there so that you can satisfy the requirements. Oh, thank you, Dr. Kotke. She has just put something in the chat box. So if you're able to see the screen, you can click on that link and it will take you straight to the documents. Is there anything that you want to add, Dr. Kotke, in addition to what I've already shared?
No, thank you. I think that was really great. Yeah, I think one of the things that we're hoping as the collaborative is that anything that we do here will satisfy the needs from the Joint Commission, so that you're not, this is 2 birds with 1 stone, hopefully, but ensuring that the folks who are doing compliance and kind of any folks who might be at the table for meeting Joint Commission accreditation, just making sure that they know what you're doing so that you get credit for all this amazing work that's already happened.
Great, thank you. And thank you, Marilyn. You just shared something in the chat box that at Memorial University, prior to your upgrade, your EPIC upgrade, you required that the PPH risk assessment was done every shift, and that helped with meeting the requirements. Marilyn, can I just ask you, was that something that was done as a result of these new perinatal standards, the new standards for perinatal safety?
No, we've done that for several years, and that was just part of our required documentation. We included that. I mean, we all know that people just don't hemorrhage in labor and delivery. They hemorrhage everywhere. So when the A1 project was rolling out, they really wanted you to do it like on admission and then 30 minutes prior to delivery and within the first hour afterwards. But we felt like it needed to continue on to mother baby too. And then we have patients that are admitted to our antepartum unit, and we really needed to document their risk on admission to the antepartum unit because some of those are emergency sections in the back, and so we need to have that risk already documented prior to going to L&D. So that's what we did prior to the upgrade. It was not built like that in the upgrade.
Right.
And so that's something that we have put in a request for, is to have it be required documentation. I know that they're going to add it to the admission assessment. I'm not sure how they're going to do it on admission to mother-baby. The only way I can figure they can do it is to make it required documentation. So right now we don't meet the standard, but we have for the last several years.
Okay, that's great. Thank you for sharing that.
You're welcome.
Anybody else? Oh, thanks, Kelly. So you perform PPH risk assessment on every shift on L&D as well as postpartum. So this is great. It's great to hear that other facilities are doing that. And Kelly, can I ask you, is that done in your electronic medical record? Is it done electronically, or do you have a form that you use? So Kelly, is it done electronically, or is it done with a form? I'm sorry, I just saw that. Yes, it is. Yeah. Oh, thanks, Kelly. Part of your shift assessment, wonderful. And Carla, in Augusta, it's built into your admission history as well as Q-shift documentation. Great. So we're getting some really great feedback. This is good. This is really good communication, because for those facilities that are not yet doing it, we know that there are lots of you already doing it, and we've got some great resources there. And thank you. Again, you do it until discharge, Kelly. Thank you at Colquitt. And Cerner Power Chart Maternity for documentation at Augusta. Great. This is great. Thank you guys for sharing. Okay, we've got a lot packed in today, so we'll move on to the next slide. Okay, so process measures for hemorrhage. I don't know if we've got Sabrina on the line.
I'm here.
Oh, hi, Sabrina. Are you able to speak to how we're doing with our data?
Sure. So as you can see in our process measures, we've had a little bit of an increase from our last quarter. Our biggest improvement could be seen in the hemorrhage protocol for provider education, as it went from right around 55 to close to 70%. So that was a really great jump. If we want to go to the next slide for the structure measures. As you can see, we've also been having a positive trend here. We do have a cluster of the unit policy procedure, the EHR integration, and for debriefing, but they all seem to be increasing at a steady rate. So I think as long as we all keep working on trying to initiate all of these structure measures, we should be able to hit our goal by 2020. So next slide, I guess.
Wonderful, great, thank you. So, Dr. Kokke?
Yes. So I just want to thank Sabrina for putting those data slides together, and all y'all for contributing to making them. I think that's actually just is a beautiful picture of the enormous amount of work that everybody on this call has done, and I think it's really exciting to see. I think it also highlights for us some areas that maybe we can help and kind of focus some of our future energies. So thank you for responding to the inquiries for data collection and for filling it out and for putting it together. I think that is remarkable. This slide is about implicit bias training. Y'all will remember that over the past, more than a year now, we have acknowledged our need to focus on equity for our maternal child health outcomes here in Georgia. And we have put together a group of folks from the collaborative to talk through multiple ideas of ways that we might be able to start working in this very important area. And a couple were highlighted as critical for us to start doing immediately. And one of those is implicit bias training for providers and nurses in labor and delivery units. And so that is now being added in the next, so coming in 2020, in our data collection for our process measures, we are adding implicit bias training to those measures because we think that this is a really critical area for us to focus. So we wanted to make sure that y'all had resources available that you could start to incorporate at your hospital level, but also wanted you to know that essentially we're working on some future opportunities that you'll hear more about over the next couple of months, and those include opportunities for Train the Trainer on implicit bias, online training opportunities, and then we're hopeful to have some options as well at our annual meeting in April. Thanks. Next slide.
Thank you. So we'll go into our content today, and we're really excited to have sharing from the team at Grady Health System. They're going to share what they did to use some tools to do an OB hemorrhage risk assessment. So I'm going to introduce our speakers for you today. We've got Grace Sobers, who's a board-certified women's health nurse practitioner with 15 years of experience in women's health and high-risk OB. She has a BSN from Howard University and completed her graduate studies at Georgia State University. Grace served as a perinatal advanced clinical nurse educator at Grady for 3 years and is currently working in high-risk obstetrics quality improvement with Kaiser Permanente. Her co-host is going to be Carlotta Eversley Gabrielle, who earned her bachelor's degree in nursing at Georgia State University, graduating magna cum laude. She's a member of Phi Theta Kappa and the National Dean's List, and eventually obtains a master's degree in nursing education from Walden University, graduating with honors and becoming a member of Sigma Theta Tau International, the Honor Nursing Society, and she's currently pursuing her doctoral degree. So we've got these very accomplished ladies. We thank you both for being on the line today and for sharing with us. And then you can let us tell us when you want us to advance the slides. Thank you, Grace and Carlotta.
Thank you. Thank you. Well, good afternoon, everyone. Again, I'm Grace Sobers. And I am Carlotta Gabrielle. And we have been given the distinct honor to be able to talk about some exciting projects that we have going on here at Grady. We developed an OB hemorrhage quality team where we were able to develop a risk assessment tool for our hospital. We specifically are going to be focusing on for the sake of this presentation, the recognition and prevention element of the OB hemorrhage bundle. Okay, so just to give you a little bit of history about Grady, is that Grady is a 970-bed public academic medical center here in Atlanta. We do serve as one of the 6 regional perinatal centers here in Georgia, serving about 42 counties in North Georgia. We have a delivery population of about 2,500 deliveries per year, and that's an estimate. And when we were doing this project, we had an opportunity to kind of do our own quality review. And in that quality review of our deliveries, we were able to see that 94% of our patient population is classified as high risk. So we have a significantly high risk population here at Grady. And approximately 11% of those deliveries are complicated by postpartum hemorrhage. In a deeper dive of that quality review that we did, we were able to identify that 7.5% of our preventable pregnancy-related deaths over the past 40 years were actually complicated by a postpartum hemorrhage. So, this isn't unique information. This is all information that all of our facilities share as it pertains to the maternal mortality rate here in Georgia. Next slide. So what we did is we followed the model of the multidisciplinary approach. And this was it was a push from executive, leadership and nursing leadership to align with the call to action from Joint Commission, ACOG, and GaPQC and AIM. All of these organizations, of course, have called all of us to come together to collaborate and reduce our maternal mortality rates. So with that, we wanted to build within Grady a culture of professional collaboration. In previous years, that's not unique to Grady, but we have, worked in silos, just like any organization, trying to get everybody on the same page as to how they're going to work towards one vision. It can be a bit of a challenge. So the way we wanted to do this particular project is we developed a multidisciplinary team to where we wanted to make sure that all of the stakeholders were at the table for this initiative. Something that's unique about Grady is that Grady is staffed by 2 medical schools, both Emory University School of Medicine and Morehouse School of Medicine. So we wanted to make sure that we had representation from both schools. We also had representation from our anesthesia department. We had nursing staff from all areas, including labor and delivery and mother-baby. And we did have representatives from both day and night shift to make sure that we were, accounting for all areas within our service line. Our nursing education department, Carlotta and I served as educators and coaches on this project as well. We had pharmacy that was available. We also worked very closely. We are an EPIC facility, so with our health information management technology team, which is EPIC, our EPIC team worked really close with us, and we had a quality officer that was from the quality department that was assigned specifically to our area to work alongside us. So as you can see, we hit it on all points to be able to work synergistically together to reach this common goal. We did, when needed, we did call in our ancillary departments such as, blood bank, facilities management. Those are the ones that come to mind. Those are the people that we did call in when we needed. If we had like a specific part of the project that needed collaboration with those departments, then we would work with them and invite them in to collaborate with us. When we developed this team, task force, or risk assessment team, what we did was we had standing meetings on a weekly basis. When we did the standing meetings on a weekly basis, it was tough in the beginning just to make sure that everyone knew that this was something that we were committed to, and we needed to be there every week, accountable for, what we're doing. We utilize these standing meetings to disseminate information, critical information, discuss important details about the project, do a spot check on our aim. Are we still working towards what it is that we need to be doing? Are we kind of veering off onto the to the side? We wanted to make sure that we were stuck to our aim. To also hold people accountable, we did assign tasks to individuals that were on the team. So every week we would get an assigned task to a portion of the bundle, and we would be able to come back and report out on the various portions of that bundle. We also utilize these weekly meetings to maintain momentum, because anytime you work in a facility as complex as Grady, there's always competing priorities, and with those competing priorities, it's easy to get derailed. But this, having taken a stance on how we're going to run it, we were able to sustain it and stick to it so that we were able to accomplish our task. Next slide. We did develop a key driver, and keep in mind, at Grady, we are implementing the entire AIM bundle. However, for this, like I said in the beginning, for the sake of this presentation, we're only going to talk about the recognition and prevention element. And so this was the recognition and prevention element that was connected to our AIM. And our AIM bundle was to improve the quality of care of women experiencing OB hemorrhage within 24 hours while receiving care at Grady Health System. And in this, we developed two main goals, was to develop a standardized assessment of hemorrhage risk factors and implement a OB hemorrhage risk tool. In turn, with that assessment being done at the appropriate during the prenatal period, assessment period, and other times. So we were able to refine this as we started out. We started out with a similar aim, but we kind of had to tweak it as we went along. But this was the end all for the risk assessment, and this was our goal. We used this to help us assign, like I said in the previous slide, that we use this to assign projects to task members so that they could carry it out and provide feedback at our standing meetings. Next slide. Okay, so
can you put your phones on mute? I'm sorry. I think I hear some background noise. I'm sorry, Grace.
That's okay.
I think somebody might have put their phone on hold.
Yeah.
Can you tell me which phone number you're on?
Which phone number I'm on?
Yeah, is it 706-475?
No.
No? Okay. Do you know the number? I'm going to try to mute the one that is giving us
Do
the
I know the number I'm on?
Uh-huh.
The number I'm calling from is 470-829-9951.
Okay, I'm going to try to mute other lines.
Perfect.
Okay, there we go.
Does that work?
Thank you, Katie. Thank you.
No problem.
You're welcome.
Oh, that was really cool. All right. So anyways, we adopted the A1 postpartum hemorrhage risk assessment tool. It was, and as we all know, that this tool was developed to risk stratify all admitted laboring patients into either low, medium, or high risk categories. And Grady was one of the many pilot hospitals for the postpartum hemorrhage project with A1. So when we sat down and worked with our physician partners, nursing played a really, critical role in advocating for the use of this particular tool when we developed this project. It was already implemented or integrated into our Epic charting system, and so it was very tempting, as any having this tool built into your system is really tempting for us to utilize it as soon as we saw, oh, it's available, let's pick it up and use it. However, we decided to use the, Plan, Do, Study, Act methodology in order to, do small tests of change, roll it out on paper to ensure that it was hardwired within our workflow prior to, putting it in the electronic medical charting system. So what we did when we did the rollout was we sat down with our nursing staff and we held focus groups. And these focus groups were people with various experience levels from both units, labor and delivery, mother-baby, that were able to provide feedback about the usability of the tool and giving us really creative ways as to how to work it into our everyday workflow. Because as, team leads, we weren't necessarily utilizing the tool every day. We were overseeing the process. So I want to kind of go back for a second. When I talked about the interdisciplinary team, there was one critical element that I missed. When we developed this team, and I think one of the things that was so critical to us being successful at this was that this team was led by our physician lead, who was, our physician liaison, and then we also had a nursing lead. And our nursing lead played a very instrumental role in both of them. Really, it was important for the culture shift that was taking place in order for us to get the different disciplines buy-in, for everybody to be aware of why this is important, why we need to be moving forward with this. It was really, really helpful to have those two individuals be the face of this initiative. So that was very, very helpful. And they also led the group. So that was a critical piece that I missed. So going back to the focus group, we held these focus groups. They gave us feedback about the usability, and they gave us information about the workflow. And that was really helpful. And during that time, what was really helpful about it was when we did roll it out, they also served as unit-based champions when we did roll out. So they served as our champions to be able to communicate with the staff what the new initiative is and to help us drive this initiative. So the criteria, let's go to the next slide. The criteria that we utilize is consistent with A1's recommendation, is that we do it on all admitted laboring patients. And I know that this might be, one of those things that you assume that the assumption is that, yes, of course we do it on all laboring patients. But here at Grady, that's something unique, is that here we see all pregnant patients, both non-viable and viable patients. And so with that being said, we had to make sure that we specified that this assessment was only going to be done on patients with a disposition of admitted and laboring. We decided to do it at admission. We conducted the assessment again at 7 centimeters dilated, and then again within the 2-hour postpartum recovery period prior to their transport to mother-baby. This questionnaire, again, is very consistent with what the A1 recommendations is, and so when you look at the slide, you'll see actually what it looks like in our electronic medical charting system. But it's composed of patient responses to various questions that ask about, how many deliveries they had, if they had a history of a previous hemorrhage, if they had a previous uterine scar. These are all other, just a couple of questions that are included in the tool. It also took into hello?
Yeah, thanks for getting it.
Hello? Can you hear me? Okay. We also took into account the patient's past medical history, labs that were auto-populated from the electronic medical charting system. And again, all of this was put into the system for us to calculate a score. Okay? Once the score was calculated, then we would move on to our, our coordination of care. We're going to go to the next slide. If you look over to the right of the screen, you'll see that once the score was calculated, you can see it on our OB track board. And on the OB track board, you'll see, just like any labor and delivery track board, what room the patient is in. It gives you critical information about the patient. But on this particular, where the risk assessment is right in the middle, it says PPH admin risk time score. It tells you, it'll give you the visual indicator of a red, yellow, or green dot on the computer to let you know whether the patient is low, medium, or high risk. It will also tell you if the patient has never been reviewed, and then it will give you the time period in which it was last reviewed and if it was increased or something. So say, for instance, we did a risk assessment on a patient that was admitted, and she was low risk on admission, but then somewhere along the line she developed choreo, or we suspect shoulder dystocia, or something changed. With that being said, then once I do this assessment again, then it's going to repopulate her risk score. So it would tell you whether it stayed the same or if it increased, and if it increased, by how many points. So this was a visual indicator in the system. So in addition to this visual indicator in the electronic medical charting system, we also chose to do visual indicators on the doors of all of our admitted patients. And this was to create situational awareness for everybody on the team. And we decided, it was funny because we decided to go with hearts, because when we actually rolled this out, one of our teams, it was actually Carlotta, who mentioned, we're going live on, Valentine's Day. Why don't we just do hearts? So that's how we ended up with the heart. And that was kind of cool. So on Valentine's Day, it was a big, big deal. But as you can see in the picture, when they're, given a risk score, they're given a visual indicator on the outside of their door in the form of a red, yellow, or green heart indicating whether they're high, medium, or low risk. And then on the back of this card, if you take that laminated card off and turn it over, it actually has the appropriate interventions listed on the back. If the patient is high risk, the hemorrhage cart should be, posted outside of the door, just as you see in this particular picture here. Does she have 2 large bore IVs? Is she typed and cross matched? All of the things that were recommended. Now, of course, we had to tweak those things, that are, that would be unique to Grady. Something as simple as the type and cross match. If we did a type and cross match on every patient that we saw, we might not utilize all of those resources. So we worked with our blood bank to see how soon could you get type and cross-match blood to us in the event of a hemorrhage. So those are things that when I say we tweaked it to work for Grady, we worked really, really good together to make sure that happened. So what was expected from everybody when we utilized this tool was the expectation was that we communicated this in all safety huddles. We held safety huddle twice daily, and we usually have it at 8 a.m. and 8 p.m. for the day and the night shift. It is an interdisciplinary huddle. And in this huddle, we're able to discuss, we don't just discuss hemorrhage scores, we talk about everybody, all of the patients statuses. We talk about what their risk assessment is, and it's a great time for us to coordinate care. Everybody's present. You have anesthesias there. The charge nurses from the various units from, mother baby will come over, NICU will come down. So everybody's in there to hold the interdisciplinary team, and we disseminate information during this huddle. It was the expectation that all staff communicate this in FBAR handoffs, during shift reports, and even interdepartmental handoffs. So this score would follow the patient. Even though the actual assessment questionnaire was done on labor and delivery, it would follow the patient from admission on labor and delivery to discharge on mother baby. So when you get over to mother baby, you see just as many red, yellow, and green hearts with the appropriate interventions put on the backside of that card for the nurses to be able to communicate that information. One of the things that we did as far as adherence is concerned, our charge nurses, let me go back. One of the great things about doing the interdisciplinary huddle and watching this become your culture, it was like really inspiring that, being in huddle and hearing somebody, a nurse or somebody from the team say, hey, did you get a risk assessment? What's her risk assessment score? Just in case someone missed it. That's how we knew that this is something that had been, ingrained into our culture. So that was a major win. And so, that interdisciplinary huddle was critical. Adherence, we monitored adherence daily. And again, like I said, our quality officer, who happens to be on the line, Nakia Worrell, did an amazing job at providing us weekly information about how often, how many risk assessments were done, how many of them were complete, how many weren't complete. And she also worked really hard to do chart reviews to help us understand why they weren't done. Two of the most common reasons as to why they weren't done was nursing staff, nurse staffing and precipitous deliveries. And that's a no-brainer. If we're short-staffed, nurses, we never really have time for much. And so sometimes that assessment doesn't necessarily mean that it wasn't done, just means that it wasn't documented, But again, if it's not documented, it's not done. But prioritizing that is getting done. But those are the two things that we saw that were preventing us from getting it done. I'm trying to think if there was anything else. For the implementation, that's really it. That's kind of what we did as far as from labor and delivery transitioning over to mother baby. I'm going to turn it over to Carlotta, at which time she's going to talk a little bit about our results. Next slide.
Thank you. So our results, as you guys can see, we started this process, as Grace eloquently explained. The process started since, I think it's the mid of 2017, going into 2018. So this actually was a process, and as you guys can see, that in 2018, this is where of course, our adherence rate was. And then 2019, which of course is this year, this is where we're at. So we're at a 90%, which is awesome. I want to talk a little bit, and I'm actually going to kind of reiterate what Grace said, because one of the things that has helped to keep the adherence rate is the audit tool that we are consistent with. It's done weekly and monthly. We do a risk assessment, and we have an audit that goes out weekly, and then we have the monthly, and our, Dr. Worrell, she gathers all information for us, and then we will sit down and we will look to see, how many moms, how many risk assessments was done, how many wasn't done, and the reason why it wasn't done. We have a graph compliance by each day and week. So every day, if there is no risk assessment done, the graph would of course represent that. There. If you guys could go forward, please. Next slide.
Oh, go back. I'm sorry. Go back.
Sorry. Yes. And on that, we have a percentage of over the RAT that is completed, and what is not completed, we will check to see what were the reasons why they weren't completed. And it was a work in progress. You know, we didn't get our adherence rate actually was high for one at the beginning, and then we kind of dropped a little, and it's one of those things that we have consistently been working on. The next slide, please. And as you can see, the slide is showing where our postpartum hemorrhage rates were 2014 to 2019. In 2014, we were at a 7.2%, and 2015 it was increasing. 2016, it's here. In 2017, we were at our highest, and we started to trickle down in 2018. And of course, 2019, we're at our lowest. We are at a 7.0%. One of the things I wanted to emphasize on is that currently this is a hardwire in labor and delivery. This is a process that has started in labor and delivery. It has worked well. It is, everybody is really, we are seeing the effects of the work that was put in, how it was done in labor and delivery. The goal is for mother baby, for us to be able to do exactly what we did in labor and delivery. We need to do it in mother baby. One of the things for our Joint Commission perinatal standards, they're saying that we are supposed to do the postpartum risk assessment in mother baby. So the goal is, and we have actually started a process where we will be trying to hardwire it in mother baby. In terms of the visual clues, it really has been helpful to our nurses, to our leaders, to me, the educator, because as I make round every day, I can see what is going on in our floor. I get a pulse for, how many postpartum high risk we have, how many medium risk, and, who, of course, is not at risk. And we discuss in huddle every morning. Here, guys, we have 10 high risk, we have, 3 medium, and so forth. So with the situation awareness and the visual clues, it's helping not just the nursing, our leaders. We are all able to work together to be able to mitigate and make sure that we are compliant with the risk assessment tools. I'll pass it over to Grace now.
Thank you, Carlotta. So as you can see, we learned a lot. In this process, when we presented this at A1, it was 18 months ago, but it's been over 2 years now. It's really satisfying to know that our work with this team directly decreased our OB hemorrhage rate by 3%, which is a big deal. So in addition to our clinical improvement in the identification of postpartum hemorrhage risk, this project also fostered a culture of a multidisciplinary culture of collegiality and problem solving. In addition to that, it ignited a fire in our nurses to become more involved in quality improvement. I feel like this project served as kind of like I'm going to say as a model for the rest of our quality projects that we have going on within the department. The culture shift has now become the standard of quality improvement within Grady Memorial Health System and Women and Infant Services. And we continue to work in establishing all of the elements of the AIM hemorrhage bundle. And again, we do participate in GaPQC, so we're reporting out our information to make sure that we're doing our part in helping to reduce the Georgia maternal mortality rate. So what I do want to do, next slide. I do want to take a second to thank our team, because we couldn't have done this without all of the people that were on our team. A special thank you to Dr. Michael Lindsay. A special thank you to Dr. Nakira Worrell, Carlotta, and all of the people that are named here. They really did an exceptional job. But I want to take a second to personally recognize Kate Hutchins, is one of our nurses who started at Grady about 3 years ago when she was a nurse resident. And this is a great example of how doing projects like this can really inspire people. When she came on as a nurse resident, she took to OB hemorrhage as one of her PICO projects during the nurse residency program. And she was our nurse lead on this OBQI team. And this is not the only part of the OB hemorrhage tools that she did. She also implemented or assisted in implementing the use of our OB hemorrhage cards. What else were we doing? The narrator that we're doing a lot of things that we're doing. But this was her baby. And the cool part about it was that during this time, she actually brought a new addition, next slide, into her family. And she, too, like many of our patients, was actually high risk for hemorrhage. And because of the implementation of I like to end with this because of the implementation of bundles like this, it really hits close to home because she was able to deliver safely with fast, with people responding really fast to what she had going on when she delivered. Mommy and baby are at home doing well. So I wanted to take the time to share that because that's a story that hits close to home to us. And, we just want to thank everybody for participating, and thank you for listening to our presentation.
Thank you.
Thank you. Thank you so much, Grace and Carlotta. Really great work at Grady. We do have a time crunch, so I am going to ask if anybody has any questions, please either put them in the chat box or forward them to me, and I can forward them to Carlotta and Grace, just in the interest of time. We want to be able to allow our other speakers to share some of the great work that they're also doing. Thank you again to the team at Grady. Great work, great models, and we appreciate you sharing.
You are welcome. Thank you for having us.
Thank you, ladies. So I'm going to introduce our next speaker, which is Carla Allen. She's the nurse manager for perinatal services at Augusta University Medical Center in Augusta. Carla has been at AU since 2004 and held various roles in perinatal services as well as in NICU. She has a Master's of Nursing Leadership and Management from Western Governors University and is certified in inpatient obstetrics. Carla is in her second term as Secretary-Treasurer for A1's Georgia section, and she's also the nurse lead for both the PPH and hypertension GaPQC initiatives. Thank you for joining us today, Carla, and thank you for sharing the great work that you're doing at Augusta University.
Thanks, Lauren. Hey, everybody. Just in speaking with Lauren about some of the things that we're doing, although this isn't specifically related to our metrics surrounding postpartum hemorrhage and hypertension, we wanted to share with you today about our implementation of our OB emergency department. Next slide, please. So just wanted to discuss how and why we formalized our triage into an OB emergency department rather than just regular labor and delivery triage. Wanted to share with you guys some of the screening tools we're using in our OBED and then the impacts on maternal care that we've made by addressing the care of our postpartum patients. That was one of the things that when we were implementing this change that was super important to me in helping improve maternal morbidity and mortality was making sure we were seeing these postpartum patients because I felt like they were getting left out by sitting down in our ERs or going to our rural ERs and seeing physicians that were not as comfortable with these obstetrical changes that you would see in the immediate postpartum period. Next slide, please. So we are a regional perinatal center here in Augusta. We do approximately 1,400 deliveries a year. We decided to start July 1 of 2018 a new service line doing the obstetrical emergency department. It's the area's only 24/7 OB emergency department. We have physicians in-house 24/7 here, partly because of our residency program. We are seeing moms from 20 weeks, also seeing postpartum moms again up to 6 weeks out, so that we can hope that we can reduce some of our maternity mortality related to our postpartum patients. Next slide, please. So we had interdisciplinary planning meetings to get this started, starting in January of 2018. We identified some of our nursing super users to help us with the policy and the workflow because what better way are you going to get buy-in from your staff for a new change in your workflow than having them engaged? And as part of that, they also helped us with an implementation plan for how we were going to staff. I'm not sure how many of you do your triage this way, but prior to this, we were doing triage of whoever walked in, the next nurse up kind of got them. We didn't have a nurse that was dedicated to doing triage. So this really helped that piece of the process as well. All of our nurses completed the A1 maternal fetal triage index training in May and June of 2018. We got an ultrasound dedicated just for our obstetrical emergency department. And then we also have an infant warmer placed there for any precipitous deliveries. We did a marketing campaign here locally in June and July to get ready. And then the picture that you see there is one of our brochures that we did that we provide in our offices. We have several rural providers and providers out at our some medical clinics here in town that aren't obstetrical providers, but they send all of their OB patients to us for delivery. So they also have these flyers in their office. That way their patients know how to contact labor and delivery. They know when they should come in. We felt like giving them warning signs early on about when to present was very important. Next slide, please. So our triage assessment form we built out based on our regular emergency department assessment form here, again, based on some comments I put in earlier. You guys know that we use PowerChart Maternity, which is a Cerner product. But we had our emergency department friends help us with all the things that are required for when you have an emergency department visit. You guys will see on the bottom of the photograph, it talks about tracking groups and tracking tools. We assigned a tracking acuity for every patient that comes in based on their complaints. That's using the A1 maternal fetal triage index. And what that does is when the nurses chart that, it automatically goes to our tracking board, which I'll show you guys in a few minutes. In addition to that form, we also have our OB triage, our IV, which is our flow sheet, and those are the things that are included in that. One of the things is the gestational hypertension evaluation. So we start talking to all of our patients that come in. We do an assessment of if they have any symptoms. Even if their blood pressures aren't high, we ask these questions of everybody, which we think is very, very important. Next slide, please. The level of acuity, again, is assigned based on chief complaint. Level 1 is the most acute and should be seen immediately. We color-coded our tracking board, which is the picture you see there on the bottom left, based on the same colors that are on the maternal fetal triage index. We have that maternal fetal triage index posted at our nurse's desk. We also have it posted in both of our triage rooms for our OBED, and then we also have it posted in the resident room. That way they can see if they're looking up at their tracking board what the colors are and what those means and how prompt their evaluation needs to be. Next slide, please. We also implemented here around the same time using MEOW scoring. Some places call it MUSE, which is maternal early warning signs. Because we used MUSE here as medical early warning signs for our ICU patients, we decided to call it MEOWs. That was the recommendation of Phillips. And so we have the scoring that you can see here that goes over what their pulse is, and they get a score for that, their blood pressures, both systolic and diastolic, their respiratory rate, their SpO2, their level of consciousness, their temperature, and their urine output. When the PCTs, this is actually also built into our MP5s, which are our vital sign monitors. So when our patient care techs are out on our mother-baby side and our antepartum side and they're doing vital signs, it actually will give them a score for the vital signs. If they get a score of a 3 or higher, it automatically alerts them in yellow on their machine to notify the RN immediately. If it gets a score of above 6 on the machine, it'll actually notify them in red to talk to the RN right then so that the nurse can come in and complete that assessment. The cool thing about MEOWs to me was that it not only looked for signs and symptoms of sepsis, but it also gives you sort of early warning signs for postpartum hemorrhage as well as preeclampsia. Next slide, please. We have the postpartum hemorrhage risk scoring. We do a pre-birth scoring on all of our antepartum patients, intrapartum patients. It's also done at admission and on every shift. Just like the previous presenters, our tracking board has the red dots or yellow dots to indicate whether they're at moderate or high risk. And we are doing the post-birth scoring as well on all of our postpartum patients. And any postpartum patient that presents back in our OBED, they are doing the postpartum hemorrhage risk as well. Next slide, please. This is just some of our OBED data to show how many patients we're seeing. We saw a 20% increase in the number of triage patients over what we had seen in FY18 during FY19. But you'll also see we're averaging a little over 20 patients a month that are postpartum. with this patient population, what was really interesting is the number of things that we caught, not only postpartum preeclampsia symptoms and wound infection, but we also saw several people who had more cardiac complications. Next slide, please. So this shows our hours, arrival to decision, arrival to MD assessment, and arrival to RN assessment. This was data we had to track because we were implementing an emergency department. This was one of the reportables at the time. It has since gone away as a reportable for emergency departments, but we are still tracking it. Our goal when we started was 2 hours or less, and you can see we were right at 2 hours and 29 minutes for our first year. And then arrival to MD assessment was 41 minutes, and arrival to RN assessment was 11 minutes. And that arrival to decision is decision to discharge or decision to admit. But for those of you who've ever been to a regular emergency department, especially one as busy as ours here at AU, our average time to MD assessment being 41 minutes is light years ahead of what our emergency room would be downstairs. So this is another reason for us that it was very important to get these postpartum patients up here so they could quickly be assessed and seen. Next slide, please. We review all of our statistics at our monthly perinatal quality meetings. We're continuing to work on getting decisions made at less than 2 hours. And then we also use the post-birth warning tools and an OBED information card to direct postpartum patients back to our OBED for care once they are discharged from the hospital. So they all get those A1 post-birth warning tools and one of those little informational cards that I had in the photographs earlier. Next slide, please. So I have this as my question slide. If you guys need to reach out, my contact information is here, certainly. One of the interesting things that I think that we saw was with our postpartum population, we had somebody come in that was having an active MI, so we were able to get them taken care of very quickly into the cardiac intensive care unit. We saw at least 6 people who were admitted with postpartum cardiomyopathy. So we are seeing these women being sicker and sicker that perhaps would have been missed with diagnosis down in a main emergency room or if they had been seen in one of our more rural areas. So I'm very, very excited about this. Happy to share our journey with anybody who has any questions. Thank you.
Thank you, Carla. I really appreciate you sharing. It's amazing work, and even though it wasn't, you may have felt that it wasn't directly related to risk assessment or the bundles, it really is, because we are working to ensure that the care that we provide is seamless and that it crosses all disciplines from antepartum through postpartum and discharge. And a lot of the patients that we see are the ones that come back. So this has really been great information that you've shared with us. So thank you again for being so willing to share that. And as Carla mentioned, if any of you have any questions, Carla's contact information is on screen, but if you don't get to document that, I can also share that with you. We are close to the end of the hour. And I do want to say to everybody that's on the line, it's really important that one of the things that is great is this sharing, because it does provide such great information that we can use across the collaborative, and I know that many of you benefit from it. So if I ever ask you to share, it's because I think that there's such great work that does need to be put out there, and I really appreciate all of you that are willing to do that. So thank you so much. So our next webinar is going to be January 7th, and we are going to have Dr. McGlora from Grady Health Systems down in Cairo share about implicit bias. And we're also going to be having some information on regional training that we are planning as a collaborative to ensure that all of the facilities across the state have access to some clinical simulation drills and debriefing. So we look forward to that. Thank you all for being on the call today. Please let me know if you have any questions. Please don't hesitate to reach out to me. There will be a follow-up email with the link to the recording and also additional resources. And please, if you do have anything that you wish to share, let us know, and we'll gladly share that with everybody else. So thank you for your time. Was that the last slide, Katie, or was there anything else? And we have a new member of the team, Laura Lane, who is now joining the GaPQC team, which is great, and we'll be able to continue the great work that we're doing and to be able to provide support for you and also allow us to share some of the great work that you're doing with each other. So thank you. Have a good rest of the afternoon. Don't forget the GaPQC annual meeting. Put that on your calendars, April 23 and 24th of 2020. We look forward to seeing you there. And happy holidays to you all. Thank you, everybody.
Thanks. Have a good afternoon.
Thanks.
Thank you.